Hi, my name is Peter Weijs, and this clip is on disease-related malnutrition. This is part of the lecture on energy and protein requirements in health and disease. If you really want to dive into disease-related malnutrition, you have to go to other sources. This is just a small introduction to be able to follow the rest of the lecture, but I really refer to other material if you want to dive into this. In the clip on starvation, I already explained that energy intake and protein intake, if they are very low, they result in a protein energy loss or adaptations effect to be able to withstand lower levels of protein energy intake. Adaptations can be successful, but if metabolic stress or disease is extended, this will result in patients in low BMI and weight loss, and especially muscle loss, and then we get into a situation of disease-related malnutrition, which is in fact a variant on failed adaptation. And this leads to death. In order to diagnose malnutrition in 2019, there has been reached a international consensus on which criteria are to be used. These are the criteria, they are quite obvious, and we will stress and especially muscle loss and lower intake in the later lecture. So there are quite a very different patients to be evaluated. They are stressed by very different metabolic circumstances, and we still have to derive some general nutritional therapies, and this is really a challenge to clinical practice. So therefore we have to understand a little bit that many factors are involved and I will now specify this as muscle loss, and let us just have a look at which these factors are. Now, one of the factors is activation of the central sympathetic nervous system, which increases catecholamine, which can contribute to a catabolic loss. Then also the high level of cortisol may be a contributing factor, and a combination of peripheric resistance to growth hormone as well as insulin resistance results in what is here called anabolic resistance. You can't completely see, but anabolic resistance will be back in the lecture in the protein requirement clip. And then inflammation, and especially cytokines, very often it's called the perfect storm. Everything is hitting on muscle to lose muscle mass. So these interleukins, TNF alpha, are inhibiting protein synthesis and thereby contributing to muscle. Then also fat mass, so obesity, overweight, can contribute to the release of factors that are called adipokines that can contribute to insulin resistance and very importantly also to inflammatory response. So very often patients already have a low level of chronic response in the body, and then they become ill on top of that, which aggravates the situation for the body. And then a very important factor that is very often neglected is inactivity, not moving around, bed rest in patients in the clinic. So this leads to a pro-inflammatory state, which is not contributing to recovery in a sense. It inhibits the protein synthesis stimulation by the mTOR pathway, and it activates actually proteolytic systems. And I've named a few, but you don't have to know the details. But this means that inactivity really contributes as a catabolic factor in this system. So we have lots of reasons that muscle is catabolized. In fact, to some extent, this is adaptation, as I tried to explain in the first picture. But during disease, gluconeogenesis plays a role. Acute phase proteins are being made. Immune function has an enormous impact on the body. So we need to be able to fuel the immune system, and also tissue repair might be a large factor. So there are some factors that really are a good reason, in a sense, to use amino acids from the muscle, but then there is some level where this process becomes maladaptive or harmful, and with a persistent inflammatory response, and this leads to further aggravation of disease and eventually can cause death. Now, essentially, disease-related malnutrition is a shortage of energy and nutrients in the body due to disease. The chronic form is a slow adaptation, wasting, similar to starvation, and acute is actually a fast adaptation. Now, in the chronic form, as I explained earlier, adipose tissue can deliver most of the energy to the body, and a smaller amount by glucose, and muscle is being lost since the liver is producing glucose from these amino acids. So energy production in the short term is really results in some adaptations that I think you have to go through carefully, but I will not go into detail at this moment. And this is just an example of acute muscle wasting during critical illness that can be very severe as a response to an acute situation. And the acute malnutrition then results in, as I also mentioned, acute phase proteins, for instance, but also other substrates in the body, like lactate, because of a different level of metabolism in certain tissues. So metabolism really is changed, and glucose oxidation plays a fairly large role in this, which makes it more difficult for muscle protein metabolism to adapt and amino acids to be saved, to remain in the muscle and to keep the muscle intact. So disease really here is a major factor in muscle loss. And again, please go through these factors for yourself and try to understand what all these factors mean under these circumstances. So basically, a very simple picture is that causes of disease-related malnutrition are related to either decreased nutritional intake, increased nutritional requirement, or abnormal nutritional losses. And I'll try to give you some examples. Here, this is a study we did in nephrology, in dialysis patients, where you can see that when they received nocturnal home hemodialysis, their protein intake went up from 1.1 to 1.3, but also milk intake, and this is, for instance, because they can have more fluid, and at the same time they then also receive more protein in this form. And what you can also see is that appetite has been increased. So in fact, under the circumstances that they were on a normal dialysis, their intake was actually decreased. Increased nutritional requirements. We often conclude for cancer patients that their energy requirements are higher, but this is not always true. For instance, here we evaluated resting energy expenditure during and after radiotherapy in head and neck cancer, and you can see here that patients and controls are not really different. More importantly, there are quite a few factors that change during time. So there is not just one situation, but there is a changing situation. And what you can see is that weight here in the circles is decreasing during radiotherapy during 6 weeks and even after this period. And that also resting energy expenditure is decreasing quite a lot, up to 10% of the total original level. But then if you express resting energy expenditure per kilogram, then or resting energy expenditure per kg fat-free mass in red, then you get a very different change in resting energy expenditure. And so there is a more dramatic change in weight, and then in fact in resting energy expenditure, we could say. Then abnormal nutritional losses. This is a study we did with Weijs-Wise, studying fecal weight and energy malabsorption in critically ill patients. And what you can see on the x-axis is the fecal weight, so the amount of feces produced per day, and on the x-axis is the measured energy absorption capacity, and you have to do that by measuring the energy content of the feces, which is done by bomb calorimetry. And here you can see that if you need at least 85% of energy absorption capacity, then by this line cut you can derive that fecal weight above roughly 350 grams per day, and later this has been adjusted a bit, but so a large quantity over this limit is really indicative for energy malabsorption. So this is really a way to have a hand on this topic in clinical practice. So really summarizing, this is considering a downward spiral, the disease-related malnutrition, which disease relates to lower intake, lower cell mass, lower increased requirements, increased losses, contributing to malnutrition and contributing to complications that then aggravate disease. So in some way, clinical nutrition tries to get a grip on this and making malnutrition not worsening the disease or the outcome, but in fact improving the disease and the outcome. Thank you very much.